Hello and welcome back to the VJHemOnc podcast. Over the past few years, there have been significant shifts in mantle cell lymphoma, not just in the therapies available, but in how clinicians think about treatment strategy, patient selection, and long-term disease control. In this episode, we'll explore how frontline management is changing from established chemotherapy-based approaches to emerging chemo-free regimens and what this means for clinical practice. This podcast episode is part of a Spotlight On podcast series supported by AstraZeneca. This supporter has no influence over the production of the content. To start, Michael Wang outlines what he sees as the most important shift in mantle cell lymphoma over the last few years, particularly the growing emphasis on getting frontline treatment right the first time.
So I really think that first of all, we have learned from all our data and we have a philosophical change, is that we recognize the first therapy for the mantle cell lymphoma patients is the most important therapy, and is the point that the best opportunity that we cure the patient. Mantle cell lymphoma is such a disease that the first treatment is very effective, most effective. Second one, the response is not as good. The more lines of therapy, the less the efficacy. And second of all, that the frontline therapy for the patients who have never been exposed to any therapy, the body reserve is still there. The patient financial, social support is still there. And so the best frontline, the first therapy for mantle cell lymphoma is most important. And also, we recognize that mantle cell lymphoma is a disease of the older people. Therefore, sometimes the older people also have infections, they have cardiac diseases. And if they get the treatment of mantle cell lymphoma, the 25% of the time, they don't have a chance for the next treatment. So that makes the first therapy so important. The major change since the past many years that we have learned that we don't have to use chemotherapy anymore. We are using chemo-free therapies. So, for example, we have chemo-free combinations with a BTK inhibitor, we have a BCL2 inhibitor, and we have also the CD20 monoclonal antibody. This framework has been tested by different institutions, and some tested against the p53 mutated patients, and those are so far showed high responses over 90% and CR around 90%. So those data, we hope that we have longer follow-up data, but so far a lot of major academic centers are using totally chemo-free therapies.
So here, the key takeaway is a shift in philosophy, recognizing that the first-line setting represents the best opportunity to achieve long-term disease control, and increasingly that this may be possible without traditional chemotherapy. Building on this, David Lewis discusses how recent clinical trials are shaping treatment decisions, particularly with the integration of BTK inhibitors into frontline therapy.
I think the main change that we're seeing in mantle cell lymphoma over the last couple of years is the movement of BTK inhibition into the first-line treatment. And we've got now 4 randomized trials that have reported in this era. The ones that have really changing practice, I think, are firstly the triangle study, which I think most of us would agree has set a new standard of care for the first-line treatment of young, fit patients with mantle cell lymphoma. And I think there's 2 major changes. The first is that the addition of ibrutinib in a time-limited fashion to first-line treatment improves failure-free and overall survival. And the second thing is, if you give ibrutinib in this setting, you can drop the autologous transplant for the vast majority of patients. So I think pretty much everyone who's got access to a triangle approach would recommend that as a standard of care approach for these first-line young fit patients. In older patients, we've got the ECHO study, which is recently reported, showing the benefit in terms of progression-free survival of acalabrutinib to bendamustine rituximab, and a trend, importantly, for an overall survival benefit. And I think we do need to see how that pans out in the long run. The third approach is the ENRICH study, which is using a completely chemo-free approach and omitting chemo completely, just using a doublet approach of rituximab plus BTK inhibitor. So I think as physicians, we now have to make these choices for different patients. So I think it's very clear that if you're a young patient, I think most people recommend triangle. And if you're a patient, say, significantly older than 70 with other comorbidities, then probably we're going to go for an ECHO or BTK plus rituximab approach. But there's a big group of patients in the middle who potentially could be fit for either a triangle or an ECHO approach. And I think with those patients, it's largely a decision about whether you consider them fit for high-dose chemotherapy. And then it becomes a discussion as to whether they would like a time-limited treatment or an ongoing treatment with BTK. There may be some patients with less proliferative disease, and I think the ENRICH study and the Nordic group's Altamira study have demonstrated this, that if you have a very low-risk disease in terms of low Ki-67, absence of P53, and no blastoid disease, these patients may actually do very well with the doublet treatment of similarly BTK inhibitor plus rituximab. So I think if I had a patient like that, particularly if they're elderly, I might consider offering them a doublet approach of BTK plus rituximab.
Despite these advances, an important question remains. Are we truly moving away from chemotherapy in everyday clinical practice? Tycel Phillips shares his perspectives, highlighting differences between academic and community settings.
We have years of data to support that for most patients, bendamustine rituximab has quite a significant durability of response. And even in older patients, I think it's shown to be quite tolerable. There is old data from the cooperative group that showed even in younger patients, you can probably get a very decent and durable response with bendamustine. Even though the trial didn't complete enrollment, it appeared to be quite comparable to hyper-CVAD in younger patients. That being said, as we sort of discuss whether chemo is something that's on the way out in these sort of non-chemo regimens, I think it depends on who you ask. I think in academic centers, we are wholeheartedly trying to move away from chemotherapy, but that's because, obviously we have a little bit more experience with these other drugs, and obviously we have more options to offer our patients. Whereas in the community, I think where the vast majority of patients are treated, I don't think chemotherapy has gone away. I think regimens, they're just more so looking to add to what they're more comfortable with. So the question is, will we ever really get rid of bendamustine? That's probably not likely to happen in the short term because, again, I think with the advent of the ECHO study, it just gives more reason for community physicians to still use bendamustine just by adding the BTK inhibitor. Now, whether that's needed or not, I don't think they're necessarily going to look into the weeds. Whereas I think there's data that has even come out of Mayo to suggest that you probably can't split these drugs up and get a fairly equivalent sort of duration of response. But in the community, again, you're treating multiple different diseases. I don't think that's necessarily going to come to the forefront versus a cal is something they can tolerate. We have experience with that. BAR is something we've used for quite a bit of time. So why not give the drugs together and not think about sort of what's next in this situation?
So, while innovation is clearly driving the field forward, real-world practice still reflects a balance between newer targeted approaches and established chemotherapy-based regimens. Given this range of options, selecting the right treatment for each patient becomes critical. Next, Krish Patel explains how disease biology and patient characteristics influence frontline decision-making.
I think mantle cell really is a unique hybrid of some of our other lymphomas. I mentioned that there has been now data to incorporate BTK inhibitors with chemoimmunotherapy backbones in frontline treatment of mantle cell. And I think maybe the next incremental step is for us to define, do we need the chemotherapy alone? Can we really address the needs of frontline therapy without chemotherapy? And so there are some ongoing trials in that respect as well. I think what makes mantle cell uniquely different than other B-cell lymphomas is even though it is a rare disease, we see a lot of heterogeneity. So for example, we have really what we would consider ultra high risk patients, those with P53 aberration, high Ki-67 cytogenetics that are complex. And those patients really are not served well by chemoimmunotherapy, and typically combinations of either doublet or triplet-based novel therapies are preferred. On the other hand, we do have patients that can also present with indolent mantle cell lymphoma that may not need initial therapy and can be safely observed, but at the time that therapy is needed, typically is treated much like standard risk mantle cell lymphoma. And then lastly, I will say mantle cell lymphoma, while we can achieve very deep responses with frontline therapy, we can sometimes induce complete responses where the patient is in remission for many years. We know that it is a disease that can come back even a decade or more later. And so to date, we don't really have curative therapies for mantle cell lymphoma in the frontline setting. And so we really have to think about long-term follow-up data from frontline clinical trials to help best define the optimal approach. Because the disease can be heterogeneous, I think for all patients at diagnosis, it's important to look for P53 aberrations. So to do that by NGS testing as well as FISH. Recall in mantle cell lymphoma, we are more likely to see mutations by NGS testing than we are, for example, deletion 17p. So you want to do both. I think also making sure that our pathologists are reporting factors like Ki-67 and that we're also when possible, able to obtain cytogenetics to look for karyotype. So those would be three things that I think are important to look for in all patients with mantle cell lymphoma up front. And then, of course, having an expert pathologist who can identify those rare histologic subtypes like blastoid or pleomorphic mantle cell lymphoma helps us to think about the high-risk patients. For the indolent patients, it's a little bit different. We see this leukemic non-nodal type of mantle cell lymphoma that is typically clinically defined, low number of lymph nodes involved, small lymph nodes. And typically these are patients that may have IGHV mutated mantle cell lymphoma. And so that's another molecular factor that may be important to look for upfront.
A key driver of many of the changes observed in mantle cell lymphoma treatment is the increasing use of BTK inhibitors in the frontline setting. Dr. Patel expands on how these agents are being incorporated across different patient groups.
A lot of things happening in mantle cell, and I think a big one, as you highlight, is the shift of BTK inhibitors towards frontline therapy. So we've seen both in younger and older adults combinations of BTK-containing therapy, typically with chemoimmunotherapy. So in younger adults who historically would have received intensive chemotherapy and potentially a transplant, now have long-term or longer-term follow-up from the Triangle trial, which I think helps us to recognize that incorporation of BTK inhibitors may help us to avoid the need for transplantation in standard risk patients. I think an area that's still maybe controversial is what to do in patients who have high-risk disease factors. The Triangle data follow-up is still relatively short compared to other transplant trials, but nonetheless, outcomes are better by incorporating a BTK inhibitor into that upfront intensive chemotherapy and potentially in the maintenance setting as well. For our older adults, where historically we might have been using bendamustine-based chemotherapy alone, we have the results from the ECHO trial, which again show us that incorporation of a BTK inhibitor does improve progression-free survival. And so I think across the spectrum, we're seeing that incorporation of BTK inhibitors in frontline therapy for mantle cell lymphoma across a variety of risk groups can improve outcomes, and that's specifically for covalent BTK inhibitors. And I think many of our studies have demonstrated that there are differences in the covalent BTK inhibitors, in particular in terms of toxicity profiles. So we tend to prefer second-generation covalent BTK inhibitors like acalabrutinib and zanubrutinib. The ECHO trial I mentioned incorporates the use of acalabrutinib with BR, whereas the Triangle study was done at a time where ibrutinib was more widely used. So I think at least in the U.S., there's been a shift towards replacing ibrutinib with covalent second-generation inhibitors like acalabrutinib and zanubrutinib because of their more favorable safety profile. And certainly in the relapse setting now, if we're shifting towards more use of covalent inhibitors up front, it begs the question is what would be the appropriate agent in the relapse setting? And I think that's an area where we're still trying to define exactly what will happen. And that'll be a little bit dependent on how BTK inhibitors were used in the frontline setting. Were they used in continuous therapy models? Were they used as fixed duration, but an area for continued investigation?
Thank you so much for tuning into today's episode. We hope you enjoyed. Stay tuned for the next episode in this series and be sure to follow us on X at VJHemOnc and to subscribe to our podcasts on Spotify, Apple and Podbean. See you next time.